left, the victim may complain of dry tongue, nausea, vomiting, gas retention, lack of stool, difficult urination maybe. Complaints of a patient with abdominal trauma do not always correspond to the severity of injury received. They must be taken critically. And also in the diagnostic algorithm, you must understand anamnesis, information about the circumstance of injury, suggest to the extent of injury. What is why? If the patient is confused of his condition, allow him to devote some time to the interviews. It's necessary to clarify. The mechanism of injury, car injury, falling from the head, beating, wounds with meal weapons, gunshot of minor explosive injury. Next, very important, nature of traumatic agent. Hand, leg, and any object, leg, and with of a knife or shaping smooth boat of relief features. It's very important. You must speak patient about what's traumatic agent, and maybe other people which see with the moment trauma. Next, approximate time of injury. The data obtained with will help narrow the search for directly life treatment injury and speed up the process of resolving is issue of the need for an emergency operation. Next, very important, you must start do clinical examination. Examination is on obligatory and extremely critical stages of the diagnostic process. Clinical examination is especially significant when the victim is unconscious. The position of the patient in the for examination can provide the surgeon with certain information. First position, the patient lays on his head, pulling his knees up to his stomach, may indicate damage to the hollow organs and the outflow of gastrointestinal contents into the abdominal cavity. When examination, you should pay attention to the integrity of the skin. If there are wounds, fix their localization, shape, and size. Attention. It must be, remember, what the absence of damage to the abdominal wall does not exclude severe injury to internal organ. Percussion of the abdominal cavity is carried out in the position of the victim of his back. Identify a hepatic dullness. When a hollow organs rupture, free gas may appear in the abdominal cavity, which accumulate under the right down of the diaphragm. Cause a decrease or disappearance of shorting zones of the percussion sound of the liver region. The presence of the signs indicate the pneumoperitoneum and rupture of the hollow organs, but its absence does not exclude rupture of the hollow organs. Next, determine dullness in the sloping areas of the abdominal cavity. The shortening of the percussion sound in the lateral parts of the abdominal indicate the accumulation of free fluid in the abdominal cavity. And the next method, auscultation abdominal cavity in the early stages after receiving an abdominal injury is not very informative, but when more informative. Next, you must do laboratory diagnostic. Laboratory diagnostic is an important but purulent auxiliary research method. Concentration of hemoglobin, the number of leukocytes, and the hematocrit are determined in all patients with abdominal trauma without fault. Next method, non-invasive method examination. You must use ultrasound examination. This method the most accessible, informative, and safe method of non-invasive diagnostics. The task of ultrasound is to identify damage, clarify the nature of lesion and its severity, as well as highlight the main contaminate injury. With the help of ultrasound, it's possible to monitor change in the state of organs, in the dynamics, and determine the indication for surgical treatment in time. Next method, less informative, but you must use X-ray examination. This method is main method of radiology diagnostic of injury of abdominal cavity and retroperitoneal space in cause of open and close abdominal trauma, include gunshot and mine explosive injury. And this method more informative during trauma whole organs. And also, your favorite method, computed tomography, CT scan. Currently, occupants are a significant place in the detection of hematomas of parenchymal organs and retroperitoneal space, for again, bodies in the cause of abdominal trauma. In addition, the method allows visualization, the vascular structure and ducts of various organs using contrast. With all the variety of possibilities with method, CT scan method has its limitation. It does not make it possible to determine damage to whole organs, the wall of the stomach, intestinal, gas, gallbladder, and the urine bladder. Where dementia can be determined only indirectly, based on the presence of a small amount of free fluid adjacent directly to the whole organs. The absence of the indicate things does not mean the absence of damage. The following circumstances should also be taken into account. In order to carry out the study, the victim must be shifted and transported to a special room with linked to the diagnostic process and will make the patient condition heaven. The method of choose for invasive instrumental diagnostics is video laparoscopy. Direct and indirect things of damage to internal and retroperitoneal organs located with a high degree of reliability to resolve the issue of the need for surgical treatment. The imposition of pneumoperitoneum is absolutely contraindicate for suspect diaphragm rupture. As with will lead to the rapid development of tense pneumothorax and death of the victim. Therapeutic tactics. Next. Patient with things of life treatment, intra-abdominal or massive external bleeding are delivered to the operation room, regardless of the severity of condition. In the presence of an open injury with prolapse of internal organs, the victim should be sent to the operating room without additional diagnostics. Next, in the case of an open abdominal trauma without prolapse of internal organs in the patient with relative step hemodynamics, but complaints of abdominal pain diagnosed with muscle tension or of anterior abdominal wall and a positive Schottky-Bloomberg symptom, ultrasound data on the present free gas and fluid in the abdominal cavity, it's possible to assume penetration wound of the abdomen with damage to the hollow organ and developing peritonitis. In this case, the patient should be urgently sent to the operating room without further examination. Patient transported to the intensive care unit in a serious and extremely serious condition, but without signs of massive bleeding. Next, admission department examine patient with closed and open abdominal trauma who are in satisfactory or moderate condition without signs of intra-abdominal bleeding. And patient with closed trauma in moderate or satisfactory condition are hospitalized in the surgical department. In the home clinical examination, and examination did not establish indication for emergency surgery. So, diagnosis of an open injury is not in doubt in the presence of a wound of the abdominal wall. It's more difficult to decide where the wound penetrates in the abdominal cavity or is not penetrating. Absolute and direct signs of penetration endure. Attention. And I'm often asked you this question, and also very often during on exam, Mitroshin, Alexander Nikolaevich, and other teachers ask you these things, absolute and direct things of penetration injury. It's loss of internal organ and tissue from the wound. Leakage from the wound of intestinal content, bile, urine, with a corresponding staining of the dressing and smell. It's absolute and direct things. In the absence of above things, the diagnosis of penetration injury is made on the basis of indirect symptoms, indicate the presence of pathological contents, blood, intestinal contents, urine in the abdominal cavity. In doubtful case, when the symptoms of abdominal cavity are unclear or absent, the final conclusion about the nature of injury is made only after the primary surgical treatment of a wound of the abdominal wall. Primary surgical treatment. During course general surgery, you must start with a question, but I must repeat this question during this topic. Is surgical intervention aimed of removed non-viable tissue, preventing complication and creating favorable condition for wound healing? primary surgical debridement of a wound, if indicate, is performed in all causes, regardless of the timing of the arrival of the wounded. Primary surgical treatment include 6 stages. 6 stages. First stages, dissection of a wound is performed with a scan from the inlet, outlet, opening of the wound canal in the form of a linear inclusion sufficient lead for subsequent work on the damaged area. The direction of the incision corresponds to the topography and anatomical principles along the vessels, nerve, larger cutaneous lines. The skin, subcutaneous tissue, and fascia are dissected in layers. Focusing on the direction of the wound canal, the muscles, and dissection along the course of vein fibers. In course where the extent of the muscles damage exceed the length of the skin excision, the latter is expanded to the boundaries and of damaged muscle tissue. Second stages is remove of foreign bodies. Wounding, shedding of or eight elements, secondary fragments, scraps of clothing, free light, bones fragment, as well as blood, clots, fragment of dead tissue, what make up the contents of the wound canal to do with effective washing and the wound with antiseptic solution with a pulsate stream. Next stages during primary surgical treatment, third stages, is excision of the edges of the wound and non-viable tissue. What is it? It means excision of the zone of primary necrosis and form areas of secondary necrosis. The criteria for the preserve vitality of tissue are bright color, good bleeding, for muscles contractly in the response to irritation with tweezers. Excision of non-viable tissue is carried out in less, taking into account the different reaction of tissue to damage. The skin is the most resistant to damage, so it exists with a scalp spraying. Cutting out large round hole around the outlet inlet of the wound canal should be avoided. The subcutaneous tissue is less resistant to damage. Therefore, it exists with excision until there are cleansings of vitality. The fascia has poor blood supply, but is resistant to damage only with parts of it what have lost contact with underlying tissue exist. Muscles are the tissue in which the wound process is found develop and secondary necrosis progresses and or regresses. Scissors methodly remove adhesion non-vital muscles, brown, non-contracting, non-bleeding when removed the surface layers. Upon reaching the zone of vitality muscle, hemostasis is performed in parallel with the excision. It should be remember what the vitality muscle zone has a mosaic character. Muscle areas where vitality tissue clearly predominant small hemorrhages occur, or photos of reduced vitality are not removed. With constitute the zone of molecular shock. Molecular shock and formation of secondary, maybe begins secondary necrosis in this region. It is on the nature of operation and subcutaneous treatment. What the course of wound processing with zone depend the progression and or regression of secondary necrosis. Next stages, 4 stages, is surgeon on damaged organ and tissue. With stages is performed for penetration wound of abdomen. Next stages, 5 stages, drainage of wound, creating optimal condition for the outflow of wound discharge. Drainage of the wound is carried out by installing drainage into the wound form after surgical treatment and removing when from a counter opening in the place where allows in relation to the damaged area with a complex wound canal. Each poked must be drainage. Next stage is 6 is wound close. The wound is suture tightly. A primary suture is applied in case of complete removal of fogate bodies and non-vertebral tissue, as well as in the absence of sinks of wound separation, and the period from the moment of injury is no more than 24 hours. Next classification of a surgical intervention. Performed for abdominal injury is based on the indication and the timing of the operation. Emergency operation are performed on the victim simultaneous with the resection aid regardless of the severity of condition. The intervention is aimed at limited violation of the vital function of body, for example, massive intra-abdominal bleeding, damage of organs of gastrointestinal tract. In the cause of a combined trauma, the decision rule belongs to the correct choice of the operating approach, the sequence and volume of operation. If there are simultaneous indication for thoracotomy and laparotomy, thoracotomy is performed first. In the other causes of combined injury of the chest and abdomen, drainage of the pleural cavity is performed when laparotomy. If there are indications for thoracotomy and decompressive craniotomy, it will sometimes thoracotomy is performed first. In patients with severe cranial trauma, regarding emergency decompression trepanation, and with damage to the abdominal organs, require emergency laparotomy. Operations are performed simultaneously by 2 teams. In cause of damage to the vessels of the extremities and organs of the abdominal cavity, operations are performed at simultaneous in the presence of profuse intra-abdominal bleeding, or at first they perform an operation on the vessels and then a laparotomy. What? No? No question. And the next causes, patient with open fractures of the limbs and soft tissue wounds are operated after laparotomy. Urgent operation are performed in victim with injury of the abdominal organs. Liver, spleen, pancreas, mesentery vessels, and with hemoperitoneum gradually increase in the course of the observation over 500 millimeters, as well as with rupture of the bladder, kidney, what penetration in the calyx pelvic system, rupture of diaphragm. This operation are performed after the stabilization of the main hemodynamic parameters. Intensive anti-shock therapy and dynamic absorption are carried out in the anti-shock recursion ward or in the operating room. Delayed operation are performed as a rule in the period from several days to 3-4 weeks after admission to the hospital for victim with intra-organ hematomas of the liver or spleen. Patient with hematomas or of parenchymal organs are under dynamic observation using ultrasound and CT scan. An increase in the volume of hematoma, a change in the configuration and size of the organ are predicted signs of a high probability of its rupture, where such victim of subject to surgical treatment. Despite the absence of intra-abdominal bleeding in this moment in the dementia, in the examination of this patient. And next, about different dementia, different organs, and starts with the dementia liver. Maybe close liver dementia, maybe depend on mechanism induced direct blow falling from the head, compression between two objects, the road induced rupture with tension of abdominal process, maybe classification and trauma by the types of dementia, rupture of liver with dementia to the capsula, transcapsular rupture, subcapsular hematomas, maybe central certain rupture or hematomas of liver, and maybe damage to extrahepatic biliary tracts and the liver vessels. And also maybe classification depend on degree of dementia. Surface crack of rupture up to 2 centimeters deep, break up to hole for the weakness of organs, break with a depth or more 1 hole weakness of the organ and through beaks, and crushing of parts of the liver, or these membranes into separate fragments. Maybe also classification depend on localization. It's damage to the lobes or segment of liver, and depend nature trauma, dementia extra and intrahepatic vessels and bile ducts. And also you must stick in the your diagnosis of your patient, open or close open liver, it means ferment and inflict with meals weapons, and also maybe combination trauma. Superficial wounds of the liver do not cause any particular difficulty during processing, and will surgeries with interrupture surgeries or supply cover and tamponade with amentum on the leg to prevent the eruption of the liver sutures, strong of an amentum on the legs, or a piece of an isolate amentum. Less often, piece of muscles, perital peritoneum, fascia, or synthetic tissue. Use often nylon, foam, rubber are placed under them. If it's impossible to suture the wound of the liver due to the serious condition of a patient, it is necessary to pack the wound with an amentum flap on the leg with sutures over the amentum. The same method is used to stop parenchymal bleeding from a liver wound. Next method operation. Next method operation, gunshot and crushing wounds with closed liver injury contain scraps of non-volatile tissue of dead bodies, with wound often separate and held by secondary attention, causing the occurrence of various complication, maybe abscess formation, peritonitis, anaerobic infection, late bleeding may be also complication. In this regard, intraoperative, it is necessary to remove dead bodies, blood clots, and scar of non-volatile tissue, and use it means P forms, P-shaped stitches. It's русская буковка P-образные узлы, швы, stitches. Indication for liver resection. Lacerate wounds and laceration with the large areas of liver damage. Liver injury with damage to the lobar and segmental vessels, leading to necrosis of corresponding areas. Damage of spleen. Most often there is a one-stage rupture with a simultaneous damage of the capsula and parenchyma with bleeding into the free abdominal cavity occurs immediately after the injury. Two stages rupture of the spleen can be considered as secondary internal bleeding. Spleen rupture is usually treated promptly. The postmortem of the surgical intervention is permissible only with precisely established diagnostic, certain or subcapsular hematoma. When observed the stretches, bed rest, and constantly observed the patient's conditions, it is possible to try to carry out conservative treatment. Splenectomy is absolutely indicated when the spleen is detached from the vascular pedicle. Multiple ruptures of capsule, crushing of the organ, bleeding through and laceration wound, ruptures and crack directly to the gate of the spleen. If it's impossible to close the spleen wound, eruption of sutures and pulp hematomas or treatment with dangerous of the two stages ruptures. If you see trauma of spleen, it's indication for splenectomy. Only remove spleen. Next organ, pancreas. Maybe next degree of damage pancreas. First, minor injury of superficial wound without damage to the ducts. Secondary degree, severe contusion of laceration without damage to the duct. Third degree, intersection in the distal part or damage of parenchyma with damage to the duct. Next stages, intersection in the proximal section or damage of the parenchyma with damage to the duct. And last, massive destruction of the head of the pancreas. The diagnosis of the open trauma is an absolute indication for laparotomy. Diagnosis is reduced to intraoperative revision. We search for damage to the pancreas and signs of traumatic pancreatitis. During the revision, the intercourse of the wound canal should be carefully traced, especially when it's passed through the retroperitoneal space of the upper abdominal cavity. In all course of the open trauma of abdominal cavity, the bursa should be opened by dissecting the gastrocolic ligament and all parts of the pancreas examined. Up to 5 to 6 hours from the moment of trauma of a gland, there may be non-macroscopic signs of acute pancreatitis. Later, the usual signs of acute pancreatitis begin to appear in the classical sequence. First, edema of parapancreatic tissue, enlargement and complication of pancreas, when the appearance of foci, of fatty and hemorrhagic pancreatic necrosis, of various localization and prevalence of corresponding change in the surrounding fiber. Surgical tactics depend on the location, extent, depth of damage, and on the ratio of the wound canal to the main pancreatic duct. In case of stop wound to the toilet and body of pancreas with damage to the main pancreatic duct parts of pancreas are removed at the level of damage. Left side resection may be used, but today early use this method because post-operative complication may be very dangerous. With stop wound to the head of a pancreas with damage to the main pancreatic duct, removal at the damaged part of the organ is most often impossible since injury of this localization. As a rule, are accompanied by massive blood loss and are combined with damage to neighboring organs, liver, kidney, duodenum, or small intestinal. Radical intervention in this situation require pancreatic duodenal resection, which is associated with high risk of death due to the severity of victim condition. What is why one should confine oneself to through hemostasis with suturing of bleeding place and damage of the damaged area. Just a minute. When the injury of gland is combined with crushing of the parenchyma, only clearly non-visual area should be resected. Suturing the resulting defect is impractical. Matching the edges of the resection leads to the formation of a closed cavity. which will contribute to the development of traumatic pancreatitis. In these causes, you should confine yourself to effective drainage of the operation area. Drainage of the operation area, amendal bursa of abdominal cavity, is a fundamentally important stage of the operation. The drainage should be laid in the amendal bursa along the enterolate of the pancreas from head to tail. Next groups organs. Hollow organs. Rupture is usually caused by blunt trauma, in which organs are squeezed between the anterior abdominal wall and the spine. As a rule, the stomach is damaged, overflowing with food, massive and air. An empty stomach is located high, and most of its covered with ribs, thanks to which it's better protected from external influence. Most often, the fixate part of the duodenum located in the retroperitoneal space is damaged. In cause of damage to the stomach and duodenum, emergency surgery is performed, suturing of organ rupture, through sanitation and adequate drainage of the abdominal cavity. And in cause of rupture of duodenum and retroperitoneal tissue. Surgical treatment for damage to the stomach consists in suturing its defect with interrupter ductal sutures in the transverse direction. An obligatory measure is the examination of the posterior wall of the stomach to identify its damage, to do with the gastroccolonic ligament is open and the posterior wall of the stomach is examined. After suturing the defects of the gastric wall, another gastric tube is inserted to decompress to the stomach. Damage to the duodenum is characterized by the presence of an insignificant amount of intestinal contents in the abdominal cavity, and a large retroperitoneal hematoma with peculiar yellowish green staining of the tissue. After dissection of parietal peritoneum, the defect in the wall of the duodenum is sutures in the transverse direction with two round sutures. With massive damage to the duodenum, a special crushing of the intestinal wall with the blunt trauma, it's necessary to disconnect the duodenum. For this purpose, a gastroenteral anastomosis is applied. Trauma small intestinal. The mechanism of close damage of the small intestinal is different. More often, it's a direct blunt to the abdominal compression between two planes with blunt trauma, or stop and cut wound with open penetration wound of the abdominal cavity. The pathogenesis of various types of morphological change is associated with the action of traumatic factors, primarily with the force of impact, with a direct blow to the abdomen. The loop of the small intestine is pressed against the spine against of bones of the pelvic. The intestinal wall ruptures, sometimes it's crushed. The intestine is separated from the mesentery, or only the mesentery is ruptured. Hematomas of the intestinal wall deserve special attention. Hematomas translucent through the serous membrane are the result of damage to the mucous membrane and muscle membrane. Extensive hemorrhage in the intestinal wall lead to the formation of secondary necrosis followed by perforation. With damage to the small intestine, as with trauma to other hollow organs of the abdominal cavity. Early surgery is the only rational method of treatment. The main goals to eliminate damage of the small intestine are wound, close, or organ resection. Isolate rupture in a limited area of the intestine are sutured in the transverse direction with a 2-row sutures with preliminary indissoluble excision of non-viable tissue. If suturing of the intestinal wound is impossible, it is necessary to perform a bowel resection. Indication for small bowel resection. Damage with regional circulation disorder. Separation of intestine from the mesentery with impaired blood flow the intestinal wall. Multiple wounds in a limited area of the intestine. The inability to suture the defect without narrow the intestinal lumen. Before resection, the boundaries of a section of the intestinal to be removed are determined. The ligation of supplying vessels is carried out in the area of the last branches of the mesenteric artery, directly going to the intestinal wall. Between the intestine and the arcade nearest to it, it is not necessary to ligate the main feeding branch of the broncho at the root of mesentery. Since with may disrupt the blood supply to the innate boring section of the intestinal, what can't by remove especially of the mesentery is diameters and sutures with blood. The latter circumstances prevent the identification of individual vessels and makes it impossible to accurately determine the section of the intestinal supply with blood from with bronchs. Next, trauma, colon injury, and rectum. Classification. You may see in this slide classification of colon trauma, close open maybe isolate plurant, monofocal, polyfocal, combined, depend on localization, blend, extendence colon, transverse colon, distendence, sigmoid, rectum. Also maybe intraperitoneal, retroperitoneal, and also maybe subserous hematoma, deserting the intestinal wall, injuries of serous membrane, wound penetration into the lumen of the organ, and through wounds. You must stay correct name of disease according international classification. The choice of surgical depend on the nature and extent of the bowel injury. If small subserous hematomas are found, it's necessary to find out if there is a hardened rupture of intestinal wall under the hematoma. If small hematomas of the intestinal wall are found, it is necessary to peritonize them with microperforation of the wall to suturize the hole. Small subserous hematomas are immersed in the fold using interrupted serous muscular sutures. Disordered areas are sutures with a sun suture. Indication for suturing a wound of a large intestine depend on the nature of the damage to the intestine itself. Adjacent organs and associated injury of our anatomical areas, the nature of peritonitis, as well as the severity to the general condition of the victim. Suturing the wound of the colon wall with the removal of decompressive colostomy, extraperitonization of a suturing area or resection like the Hartmann or Mikulich operation is performed in most clinical situations. Large intestinal resection is performed with significant rupture, exceeding more than half of its circumference, damage to the mesentery. The operation manual should be complete according to the types of Hartmann's or Mikulich operation. Most investigation concite primary anastomosis for colon trauma to be faulty given poor bowel preparation and the high risk of anastomotic failure, break anastomosis. The above operation are permissible in the early stages of surgical intervention up to 4 hours from the moment of rupture in the absence of signs of diffuse peritonitis. With extensive destruction of the left band of descendant colon, it is resect bringing out the proximal segment of the intestine in the form of a single barreled colostomy. The distal end is suturous thickly and immersed in the abdominal cavity according to the types of Gartmann's operations. At the later date with contamination of the abdominal cavity with intestinal contents, as well as with unstable hemodynamics, the area of the damaged colon is resect with both ends of the intestine being removed. It's Mikulich operation. Today, all information for you. Thank you for attention.